Hi, my name is Marlo. I'm going to talk about pulmonary embolism. Some risk factors for someone developing a pulmonary embolism are venous stasis, hypercoagulability, and vascular wall damage. An embolus is defined as any intravascular solid, liquid, or gaseous mass that's carried by blood flow to a site distant from its origin. So 95% of pulmonary embolisms, or PEs, start as a DVT. Patients that present with a PE often will have tachypnea, tachycardia, diaphoresis. They'll be cyanotic and also hypotensive. They might complain of chest pain or pressure, have a cough, shortness of breath, palpitations, hemoptysis, and dizziness. So two separate types of medications that are used to treat PEs. They're both anticoagulants, but they act in different ways. So the first one is unfractionated heparin. What that does, it helps prevent the growth of a clot and prevents new clots from forming. It doesn't actually break down the existing clot or PE. What it does is it inactivates thrombin and factor XA through an antithrombin-dependent mechanism. The other medication that's commonly used is warfarin. So typically patients will be on the unfractionated heparin and then bridge over to warfarin when they go home. And heparin works by inhibiting the enzymes responsible for conversion of vitamin K in the liver, which suppresses production. So Coumadin has multiple interactions with food and other drugs. Most common reported interactions for patients and their comfort level, I guess, is the vitamin K food, so like your leafy greens, and also cranberry and grapefruit juices. Unfractionated heparin doesn't have those sort of restrictions. And also, the good thing about unfractionated heparin is that it's usable for patients that have a creatinine clearance under 30 mLs per minute. So any of your patients with a little bit of renal impairment can still use heparin. Unfractionated heparin, I should say, takes effect within about 24 hours of it being initialized, typically IV route if the patient's in the hospital. Warfarin takes a little bit longer, 36 to 72 hours before it reaches that peak effectiveness. For both of these medications, safety is an issue. Your biggest safety issue is, of course, bleeding. So any of these patients need to be monitored for bleeding. With unfractionated heparin, they'll have lab values that are monitored, and of course with warfarin as well. So the cost, so for a 6-day course of unfractionated heparin, the cost is $37, and that's according to the Journal of the American Medical Association. And that's just based on average dosage. Whereas warfarin runs about 1 milligram dose is $19 for 30 tablets. Or if you're looking at a higher dose, 4 milligrams runs about $1 per tablet. Both of these medications will help prevent the growth of the current clot and also preventing future clots from developing. But again, they don't help break down the existing clot. That just will happen over time and with the other treatments that are being initialized. Thanks.